Hello, everyone. It's my great pleasure to welcome you to this webinar sponsored by ESOU and ESU regarding the relevance of gallium-68 PSMA in prostate cancer patients management. This is fully funded by Telix Pharmaceutical. The webinar itself is scheduled in 40 minutes presentations with 20 minutes for questions. So don't worry, you will have a lot of time to ask the questions to my two good friends that I will introduce to you a little bit later. You can ask the questions through the portal. Feel free to ask everything you want. And on top of that, ask the more serious, more difficult the question are, the best it is, because I will not be able to answer these questions. And finally, the webinar is accredited if you complete the questionnaire that will be sent by you after the webinar. It's important if you want to get the point that you complete the questionnaire. I'm Nicolas Motet. These are my disclosures with the pharma industry. So all this webinar is about something new. There are some principles in oncology. The first one is that optimal staging is an absolute prerequisite in oncology. There's no question about that. And we left for decades with bone scan, the very old-fashioned bone scan and CT scan. And more recently, we had the MRI, especially for local staging on the prostate. And now recently, we have a new major revolution, the PET PSMA. There's no question it's much more sensitive compared to bone scan and CT scan. There's no question it's much more specific. So it might be standard of care, at least standard of practice in 2021. Is it so clear? And is it so real? To try to show this, we must remember a few points. The aim of the better imaging is not only to give better images. This better imaging should lead to a better treatment that might finally lead to better outcome. If you just have nice images, it's useless. If these images translate to better outcome, that's an absolute need. The second point I want to highlight, and probably this will be one of the key points for the discussion later, is that all we have in terms of treatment modalities, all we have in terms of treatment outcomes are based on old-fashioned bone scan and CT scan, and more recently about MRI for the prostate. So clearly, we have to reanalyze and rethink on this new imaging modality that is much more sensitive, much more specific than bone scan and CT scan. And finally, this new imaging modality creates absolute nightmare new situations. The old N0, M0 becoming, in fact, either N1 or even worse, M1 based on PET PSMA. And this might lead to two completely opposite risks: undertreatment and overtreatment. To try to clarify all this, I have two very good friends with me. The first one doesn't need to be introduced any longer. It's Stefano Fanti from Bologna, who will cover an imaging perspective of PET PSMA in prostate cancer. Everybody knows Stefano, who is direct to the point and direct to imaging, almost always with the same conclusion. The second one is a very famous urologist from the Martini Clinic that might try to show you how the PET PSMA impacts the prostate cancer management. Opposed to what is written on the slide, all the Q&A will be put at the very end. So we will listen to the two talks together, and then we have a lot of time for all the questions. So the floor is yours. Stefano first, please explain to us what PET PSMA is.
Thank you very much, Nicolas. It's truly a pleasure, a honor to be here this afternoon with two great friends and colleagues, Nicolas and Tobias, try to clarify the many points already raised up by Nicolas, which I fully and completely agree with him, are very relevant for the urological, oncological, and imaging practice. So let me see if I can share my screen. As said, in the next 20 minutes, I will talk about the imaging perspective. And these are my disclosure. As you can see, there are many, but the key disclosure is that I'm proudly a nuclear medicine physician. So be aware that I'm biased of giving you a nuclear medicine, or if you prefer, an imaging perspective. That's my background. And I'm starting with a meme, which is now becoming more and more popular on Twitter and other social. That's how it started and how it's going. And that's, of course, a tribute to Nicolas, because it's a very famous French soccer player. So that's how it started for PSMA PET. That's the first publication with a human image published by the colleagues from Heidelberg, demonstrating great images with gallium PSMA11. It was 9 years ago, and superiority over F. choline. And that's how it's going. That's absolutely the bigger success we have seen in nuclear medicine. More than 1,600 articles in 9 years, more than 500 articles last year. So a really impressive amount of publication and data. And of course, this data led us to the capability to build a good literature. That's a nice meta-analysis published last year by our Australian colleagues that together with the Germans are definitely paving the way to great worldwide use of PSMA PET. They were able to pool almost 5,000 patients analyzing in this meta-analysis the performance of PSMA PET, and they were able to stratify by PSA values, and what they concluded is that it was superior to conventional imaging, and it was able to improve the detection of metastasis in the scenario of biochemical recurrence. And that was particularly true at low PSA levels, so in the early biochemical recurrence scenario. So it's out of any discussion that we were able to target very well and to get great results, for sure with gallium PSMA11, to some extent also with the many other PSMA ligand. And in this slide, I took freedom to put in red some other tracer that are the very, let's say, old FDG and fluoride and other metabolic tracer that have been somewhat surpassed and displaced by the wide use of PSMA. And that's an example of the impressive results in one of the few direct comparison, in this case is PSMA versus FACBC, demonstrating that the higher detection rate of PSMA implied that it should be the PET tracer of choice when PET-CT imaging is considered. That's another meta-analysis that I co-authored together with Tobias and many others. And in this case, it was compared not only PET tracer, but also other imaging like transrectal ultrasound, CT, bone scanning, as well as multiparametric MRI. And what was concluded is that gallium PSMA11 has a higher detection rate than any other imaging modality, especially in the range of low PSA. So, no doubt, it's the better tracer, the better images, but it was very, very properly pointed out by Nicolas. Better detection rate does not mean better clinical outcome, but nonetheless, the rationale is there. And that has led to PSMA PET being fully incorporated in the very well-known EAU guidelines. I'm sorry, I'm showing you last year guidelines because the new one has been just published this afternoon. Maybe Nicolas may comment, but I'm not expecting a striking difference. And as you can see, either after surgery or radiation therapy, PSMA PET is suggested as the first imaging method to be carried out at PSA level of course, consistent with biochemical recurrence. And just in case this is not available, then you can consider alternative tracer. It's also relevant that the strength of rating is weak. This is not due to the lack of literature about diagnostic accuracy, but as mentioned before, to the lack of literature demonstrating a direct impact on major clinical outcomes, essentially survival, for example, which has never been demonstrated into robust trial. But nonetheless, the data are fully in favor of the use. And that's another example, in this case, on PSA persistence, where again, there is recommendation to perform PSMA PET. And this is a case from our file. You can see a very young patients, very high risk situation, persistence after treatment that's been by intervention. As you can see, the choline performed is just positive at a couple of lymph nodes, and the difference with gallium PSMA11 just carried out 10 days apart is impressive, and there are many examples like that. So for what about biochemical recurrence, there's no doubt that PSMA PET has a clear clinical role, and it's currently recommended by the guidelines, the most authoritative. What about the other indication apart from biochemical recurrence? I will go rapidly through diagnostics, staging, and then I'll spend a few minutes on the therapy planning. And well, for what about identification, so primary diagnosis? As you can see, there's not even a mention of PSMA PET, and that's absolutely correct because it's all about multiparametric MRI. There's no role for PSMA PET in identifying prostate cancer. It's different for staging. Let me quote an example that's been originally presented by Alberto Briganti from Milan, EAU 3 years ago. 61 years old patient, family history of prostate cancer, PSA at presentation 12.6, undergoing transrectal ultrasound, identifying a cancer in the left lobe, then biopsy confirming a Gleason 8 in 4 coils in the left lobe. So it's a high-risk patient, no doubt. It's undergoing the standard imaging for staging. Bone scintigraphy, negative, CT, negative. But as part of a trial that we are running together with Milan and Bologna, is also studied with MRI. You can see the lesion clearly in the left lobe, and you can see PSMA PET, very consistent lesion. But you can see that gallium PSMA11 PET is allowing you to see also lymph nodal and bone lesion. So there's clear overstaging and a complete change in patient management. And that's very relevant. Now, the studies were not so really robust till last year when this nice publication came from our Australian colleagues conducting a good randomized multicentric trial comparing PSMA PET-CT with conventional imaging. That's, of course, CT and bone scanning. And PSMA PET-CT has a greater accuracy, 27% greater accuracy, that led to a management change in a relevant number of patients. So for staging, conclusion is that there is a great potential for PSMA PET, and it's likely to be incorporated into the guidelines quite soon. What about metastasis identification? Again, I'm quoting a paper co-authored by Tobias and many other colleagues in Germany and USA that studied patients with non-metastatic CRPC. And as you can see, PSMA PET was positive in the very high majority of the patient, 98%. At the same time, an extra prostatic bad localization was seen in more than half of the patient. So again, it has a lot to do with what already mentioned by Nicholas. The N0 or M0 CRPC is frequently becoming N1 or M1 at PSMA PET. A very important point to be regarding in the management. So what you see with PSMA PET is that the patient, when as a BCR, frequently it's a mass identification that moves straight to the metastatic hormone-sensitive PC, or in case of non-metastatic CRPC, again, PSMA PET, by mass identification, led the patient into the group of metastatic CRPC, and that has clearly a lot to do with the therapeutical implication. Now, I told you I'm gonna cover an issue which is really, really very important and frequently talked right now. That's theranostic. Theranostic is a mix-up, of course, of therapy and diagnostic. It's a process where diagnostic is leading to individualized therapy based on the identification of the prerequisite for therapy. In this case, the identification of a target that may lead to new medication and a tailored treatment based on imaging. It's clear that nuclear medicine is perfectly suited for that, because once that you have identified the target over the neoplasm, the malignant, the cancer cell, and in this case is clearly PSMA, then you will have a binding molecule bringing an isotope. So if you are using gallium, then you can see the cancer, you can do PET. But if you are replacing that with a alpha emitter, for example, or a beta emitter like lutetium, you can treat the cancer. A paper that most of you probably know, again coming from Peter Mac, Australia, demonstrated this principle using lutetium PSMA in this phase 2 study that has led to a PSA response higher than 50% in more than half of the population. And a couple of months ago, published on the Lancet, a randomized phase 2 trial, multicentric, again in Australia, where 200 patients were randomized into cabazitaxel arm or lutetium PSMA therapy, and results clearly in favor of lutetium PSMA therapy as compared to cabazitaxel, with a profile of safety which is similar, clearly more xerostomia effect with lutetium, but the other are essentially in favor of that. That's a very impressive case from our file. A patient, as you can see, with impressive spread of the disease. This is PSMA PET imaging to the bone, diffuse bone uptake, PSA higher than 400, and treated with the PSMA targeted therapy. And you know, it's impressive, the results after just one course. The patient treated again, because you can run several courses of therapy, and the results are really, really, really impressive, and lasting more than 3 years with subsequent further treatment. So here I am with some conclusion of this first ride, waiting for the clinical counterpart. As said, PSMA has completely changed our life, our relationship with urologists and oncologists. Now, what we can conclude is that it's a robust methodology. It's patient-friendly, non-invasive. It's an established procedure that's widely available worldwide. And we have procedure guideline. That means that how to perform a PSMA PET is absolutely clear. This is a joint publication with the European and the North American Society involved. So there's no doubt about that. And now there's also publication regarding the reporting, so the image interpretation of PSMA PET scanning. There's clear demonstration of the clinical importance, especially in biochemical recurrence. And finally, PSMA PET has been incorporated also into the ASCO guideline, despite the fact that PSMA has been FDA approved only very recently in the USA. And it's becoming more and more relevant for other applications, just like referring patients to PSMA targeted therapy. As you know, the VISION trial has just been completed, and apparently the final data are not published, but it was reported as met the clinical outcome that were expected. So with that, I thank you for your attention. That's the slide that I use to complete my talk usually, but given that today we have a German and a French friend, I added these two others. The first is very famous quotation from GFK. That's I'm a Berliner. It also has apparently a double meaning. So my quotation as a tribute to Nicolas is that, yeah, je suis apétomane. Merci beaucoup pour votre attention. Thank you very much. Grazie.
Thank you, Stefano. As usual, straight to the point and complete. Tobias, we heard a lot about images. It seems to be attractive. What the reality in clinic for that? And once again, ask your questions through the question and answer in the website, and we will summarize all the questions at the end. Tobias.
First of all, it's a real pleasure to do this webinar together with you two, famous people, and and also after Stefano's talk, what is there more to say? Well, there is something to say. We have now better imaging, PSMA PET, but what are the implications on our clinical patient management? So these are my disclosures. Well, we heard about superior detection of prostate cancer lesions by PSMA PET compared to conventional imaging. I think showing, you have seen those images, this question actually has been answered. However, does it always have to be PSMA PET for us to find the right treatment decisions for our patients? And we have now better imaging. We have nice, fancy new tool to hammer down our nails. But is this really then also translating in better outcome? Well, not necessarily. So when you consider PSMA PET, there are certain points that you need to take into consideration. One is PSMA PET available, and I will not touch on that. I also will not talk about the economical burden, the costs associated with PSMA PET, but I will try to show you again the evidence in the different clinical settings that we have. And I will try to show you the expected impact on clinical management of our patients. And I split this in two parts: number of patients that might have a change of management, and the severity, I call it severity, of change in management. Is it just this minor change, or is it really has a great impact on clinical management? There are a few situations where we use imaging in prostate cancer. And I picked 4 of them. One is suspicion of cancer, where you want first to detect lesions within the prostate. Second is staging of primary prostate cancer. Then staging, of course, of recurrent prostate cancer when you have biochemical recurrence, PSA relapse. And then last but not least, staging of metastatic prostate cancer. What is the impact of PSMA PET in these settings? And I will try to answer that in the next few minutes. Well, for prostate cancer detection, I think we still have very few and only retrospective studies that compare multiparametric MRI, which is the gold standard, to PSMA PET CT or PET MRI, even PET MRI. And also the results are not really that convincing, I have to say. When you talk about fusion biopsy, PET CT is surely not as suitable as PET MRI for registration issues. But on the other hand, and Stefano already touched on that, we have level 1 evidence for multiparametric MRI in this setting from the PROMISE trial, from the PRECISION trial. And I like very much this publication by Pane-Pianco. If you have a negative multiparametric MRI, the risk to develop clinical significant prostate cancer after 4 years is only roughly 5%. So even if PSMA PET is superior, most significant tumors might still be detected by clinical follow-up, by PSA, by multiparametric MRI, and repeated biopsy. So in my personal view, we have here very low evidence, very few affected patients, if any, and the severity of change will probably be negligible. And also the EAU guidelines, they clearly state level 1A evidence, strong recommendation to perform multiparametric MRI prior to a biopsy. What about primary staging? Well, here we see a rapidly increasing number of publications, mainly retrospective studies, review works, and you've seen the work about from Pereira, for example, reporting increased detection rates for prostate cancer lesions. And we have emerging prospective evidence, and Michael Hoffman and his pro-PSMA study was already also mentioned by Stefano. Most evidence here is for lymph node staging. Not all of the studies, but some also with histological confirmation. And here just shows some publications who had also histological confirmations. And the question here is, well, if we have now a negative PSMA PET, can we, for example, omit an extended pelvic lymph node dissection? When you look at the specificity, it's rather high, mostly above 90%. However, when you look at sensitivity, and sensitivity obviously also depends on your pathologist, it ranges from 30% up to 85%. So the sensitivity does not allow us to spare patients from extended pelvic lymph node dissection or lymph node treatment when you do radiation treatment if the clinical indication exists. PSMA PET is not perfect, and you have to remember that. And I like very much this publication where from Freiburg, from Cordula-Yilk, where they looked at the size of the metastatic lesion that needed to be detected, to be picked up by PSMA PET. And they found it needed to be at least 2.3 millimeters in size and in short axis diameter to detect 50%, 90% detection at 4.5 millimeters. Of course, this is a lot better than CT or MRI, where you usually need 8 to 10 millimeters for a lymph node to be suspicious, but it's still not perfect. Can, on the other hand, PSMA PET provide us with prognostic information? We just recently published a series of 230 patients who underwent PSMA PET and then radical prostatectomy and followed them. And we looked at those patients mainly who had positive lymph nodes on PSMA PET. And when we see a positive signal on PSMA PET for lymph nodes, we clearly see a decreased biochemical-free survival and a decreased therapy-free survival in intermediate and in high-risk patients. So we can have here maybe some, it's a retrospective study, but maybe some prognostic information. So currently we have no prospective studies, and this is what I have to say for basically all of the different clinical settings that show superior oncological outcomes for patients staged with PSMA PET. And when we split it up, the clinical setting, primary local T staging, I think here we have really low evidence. Only a few patients would be affected because most people will get treatment of the whole prostate because they have an elevated risk profile. And the severity of change might be minor. You might argue that boost radiation could be applied, but then again, we don't have any data on superior oncological outcome. Primary lymph node staging, I think here the evidence is best. It's intermediate, I would say. Some patients, especially high-risk patients, could be affected. The change could be minor to major if you take a different lymph node staging, or even if you abandon only radical prostatectomy, for example, and switch to multimodal approach. And primary metastatic staging, again, low evidence, few patients. But then when you detect metastatic lesions, it could lead to major change. The EAU guidelines, they clearly state also PSMA PET is a more sensitive method to detect lymph node and bone metastasis. The clinical benefit for this detection, however, currently is unclear. And we need, of course, randomized controlled trials. Recurrent prostate cancer, this is basically the mainstay of PSMA PET imaging today. We have a great number, mainly retrospective studies and reviews, but also some prospective studies and reporting increased detection rates. Histological confirmation, however, this is a drawback only in a minority of patients. How could now PSMA PET impact treatment? And this is, for example, for radiation therapy. It could change radiation dose. It could change radiation volume. It could change ADT use and duration, depending on what you detect now on molecular PET CT or PSMA PET. Is it a lesion in the fossa, pelvic lymph nodes, or a distant metastatic lesion already present? So there might be some impact on salvage radiotherapy. It might also impact salvage surgery. This is just an example of a young patient after radical prostatectomy with an early biochemical recurrence, PSA 0.23 nanogram per mil. The proposed treatment obviously would be radiation to the prostatic fossa. He had negative lymph nodes initially. After PSMA PET, however, this changed completely. You see now a atypically small lymph node. You could now consider radiation therapy, including lymphatic drainage and or fossa, together with a prostatic fossa, for example, or you could think about salvage lymph node dissection. Of course, experimental therapy and no proven better outcomes yet. We do have some prospective and also retrospective series that evaluate the impact of PSMA PET on the clinical management. And I like the first publication very much by Ferolfi, and Stefano actually is here last author on this one, because they really focus on a specific patient cohort, all patients after radical prostatectomy with early biochemical recurrence below 0.5 nanogram per mil. And if PSMA PET picks up something, those patients in 90% experienced a change of management. In total, for the whole cohort of 120 patients, 30% change. You look at other series, up to 60, 70% of change, which is sometimes reported as intended change or implemented change. However, again, we don't have any data on oncological outcomes yet. And the last publication, it's a review analysis of 45 studies, including different traces for PET imaging. This is also worthwhile reading because it summarizes a lot of the data currently known. So change probably most pronounced in early biochemical recurrence, but the influence on oncological outcome unknown. We do have some hints though. Last year, the Oriole trial was published. It's a trial of 54 patients with up to 3 metastatic lesions on conventional imaging. And they were either randomized in observation or in stereotactic ablative radiotherapy. And in those patients who were treated with radiotherapy, those patients also received a PSMA PET CT before radiation. However, the physicians were blinded for the results. And when you now look to the left, well, you see increased progression-free survival if you treat stereotactically those lesions. If you look on the right and you go back to the PSMA PET scan, if all lesions were covered by the stereotactic ablative radiotherapy, those patients had a significant better progression-free survival. Of course, this was a secondary endpoint. It's not really so mature data, but this is a first hint that that might make sense. So to summarize a little bit this part, we have only a few analyses available. And I think this is a point where we need to work, where we discriminate in biochemical recurrence for the primary treatment. Are these patients only after radical prostatectomy, only after radiation therapy, and the use of ADT? We have very preliminary data if the changes on PSMA PET translate really in better oncological outcomes. And here, of course, we need trials. The clinical setting, we can split it up again, but I think most impact it will have on early biochemical recurrence after radical prostatectomy in patients not taking ADT. And here, I think we have intermediate evidence. We have few to some patients that might be affected, and the severity of change might even be major. You have seen this slide already. These are the EAU guidelines on PSMA PET in recurrent prostate cancer. I just want to highlight if you have PSA persistence, and I think this is a important message, then you should, before you treat, do, for example, a treatment, a radiation treatment of the prostatic fossa, you should take the time to do PSMA PET imaging, because you might impose the patient with toxicity without benefit because he has a distant lesion. However, the strength rating is weak, the level of evidence also. Lastly, staging and restaging of metastatic prostate cancer. Here, again, preliminary results are only available from few and retrospective studies, and mostly those studies are in combination with radioligand therapy, what Stefano touched again in his talk. What I think here might be interesting is that PSMA PET offers a tool to maybe quantitate tumor volume, and this might provide prognostic information again. And here on the right, you see a retrospective study, but according to tumor volume, if a patient on PSMA PET has less tumor volume, the probability of survival was significantly better than if the tumor volume was in the fourth quartile. So to summarize this, PSMA PET offers you a one-stop shop examination. It provides you with additional molecular information on, and this is important for PSMA targeted therapies, obviously. Tumor volume measurements might provide us also with prognostic information and maybe also a better classifications with patients that were otherwise classified as having a mixed response. The evidence here however, is very low, and it's really unclear if patients really profit from this novel imaging. We don't have the data yet. The EAU guidelines, they also state the use of colon or PSMA PET scan for progressing CRPC is unclear. Prostate Cancer Working Group 2 criteria, they recommend, and I think this is the current standard, to perform clinical follow-up of those patients, PSA testing, CT and bone scan at least every 6 months. Recently, the American radiologist had an expert consensus statement also on PSMA PET, and I just want to say that also our colleagues from the US who have just gaining access to PSMA PET see this also as the most sensitive imaging modality, which will likely become the modality of choice once it is approved. And this is also to Stefano, nuclear medicine physicians and radiologists, they are actually our new best friends. Well, so to summarize, does PSMA PET impact patient management? I think yes, probably most valuable in early BCR and in primary high-risk prostate cancer. But we have very preliminary data that PSMA PET informed change of management translate really in better oncological outcome. And currently the impact of PSMA PET on management change depends really on the perception of the treating physicians. It's more like wishful thinking versus real evidence. Thank you for your attention.
Thank you, Tobias. It was perfect and straight to the point. Let me show the concluding slide, and then we'll have a lot of discussions. I show the concluding slide before because they will allow us to jump to the question. I've seen that Stefano already answered to many of them, but I do believe there are some of them deserve a little bit more discussion. So we have some evidence. There's no question that it clearly outperforms all other imaging modality in prostate. There's no question with this. The second evidence that the best data available so far are available for relapsing patients after local treatment. Let me insist on something that was repeatedly said, but I'm not sure it was completely understood, that for M1 disease, and that will be, I do believe, a major point to discuss with Thomas and Stefano, that everything we have on M1 disease is based on bone scan and CT scan. We have absolutely nothing, I insist, nothing regarding data on PET PSMA. We have some few data on PET choline. We have a a very small part of the Urology trial with PET, but the treatment was not based on PET. So in fact, we have nothing on PET in M1 disease. And the last evidence is that we have a lot of uncertainty, and Thomas very well summarized all the uncertainties, and he showed you that the benefit for the patient might be marginal, minimal, and in sometimes it might be major. But let me highlight the risks. I just referred to an editorial Philip Comfort for the Guideline Office wrote, just published in 2020, and we only focus on high-risk localized disease, where Tobias suggested that it might be of interest to use a PET PSMA at that stage, the so-called N0, M0, old-fashioned. Let me remind you, standard of care in those men is local treatment, surgery or radiotherapy, that's not the question, combined with some form of add-on, ADT with radiotherapy, and depending on PSA and pathological results, something on top of surgery. The question, and suddenly you perform a PET PSMA before the treatment and you find 3 spots outside the pelvis. And there are a lot of questions that are completely unanswered. Is it still a local treatment valid? Nobody knows. Probably yes, but we don't know. Should we then offer lifelong ADT because we have spots outside the pelvis, meaning M1 disease? Should we offer targeted therapy to these spots? Nobody knows. Purely experimental. If you avoid local treatment, you clearly do an under-treatment. You might also do an over-treatment if you use a lifelong ADT, and it's not because targeted radiotherapy is feasible that it adds anything. Even worse, you find 7 spots, mainly axial, but also appendicular. Will you deny any form of local treatment of this N0, M0 patient saying, well, he has more than 4 spots and not only on the axial skeleton, meaning it might be high volume, clearly purely experimental, or will you combine ADT plus an ARTA plus a local therapy? That might be also an over treatment. So clearly when you use PET PSMA that way, you will discover that a lot of high-risk patients previously considered at least to be M0 are in fact M1, but we have absolutely no idea what to do. And probably the mistake would be to avoid doing the local therapy. Let me remind you, all definition N0, M0, there's a clear benefit in 3 large randomized controlled trials showing that when you treat the local treatment on top of the systemic one, you improve the outcome. And to answer all this, the only way to confirm the real impact and so the real benefit of this new imaging modality in trials, there's no other way to do it. And it's our responsibility as physicians to do the trials and to put the patients in trial. Let me be very simple and provocative. If we don't do that, and we completely avoid doing that, in 10 years from now, we will be exactly where we are now with the notes. We still don't know if a nodal dissection is useful. It's better for staging. If you do it by surgery, you spend almost an extra hour doing it. You increase the toxicity of your treatment, and we still don't know if at the end of the day, we improve the outcome. And it's exactly the same for a lot of things. So do trials, that's our responsibility. And if trial is not feasible, at least, and that should be a minimum, do a well-defined prospective database with predefined criteria where you put all your patients consecutively. It will give us some of a flavor. It will not be a level 1 evidence, but at least we'll have some flavor in terms of what to expect. That was my conclusion. And now we go to the discussion. And I think there will be a lot of discussion seen based on the comments we have. And let's start with one comment to Stefano. Two questions that cover a little bit of the comments that were made. The comments are, is it easier to read a PET PSMA compared to an MRI? And the second question is, what is the false negative rate, the false positive rate of PET PSMA? False positive rate and reading a PSMA, is it much more difficult or equivalent?
Well, on a nuclear medicine point of view, it's much easier to read a PSMA PET because I've done that in the last 5 years and I've never been trained for MRI. But honestly, the number of information carried by, for example, all body MRI is not comparable to PSMA PET. You know, PSMA PET is quite simple. You are just searching for overexpression of receptors. So you're searching for a hotspot. And it's much easier than searching for different shades of gray in something like 256 or even more shades that you can see. So generally, I guess, but again, it's an unfair comparison. I should be at the same time a good radiologist and a good nuclear medicine physician. So honestly, listening around, it's easier to report PET than MRI. Regarding the false positive, that's a very good point because there's a learning curve. I mean, there are some areas of physiological uptake, or if you prefer, paraphysiological uptake that have been known and described, just like in the ganglion, the celiac and the other ganglion may uptake physiological. It's questionable if the uptake in another malignancy has to be regarded as false positive. I know everybody has seen, let's say, a lung malignancy, so a secondary tumor uptaking PSMA. Now, should we call it as a false positive or just the incidental detection of a second malignancy? The point to me is rather how frequently we see faint uptake, let's say especially in a rib or in a bone that may be called as a single bone metastasis when it's very faint. That may occur, and it's very risky. That's the reason why we say people have to be carefully trained in reading, because if you find a clear hotspot, and if you find 5 of them, the likelihood of false positive is negligible, is 0. But if you have only just one very faint spot into a rib, the risk of false positive is very high. So you have to take a look comparatively to the CT. You have to ask the patient of the history if he has a recent trauma or something like that. And we have noticed that the likelihood, you call it falsely positive, is as a function of your learning curve. So the longer you read, the more able you get at considering the very faint uptake as a paraphysiological and avoid false positive. That may be a major problem, something like let's say 5% of the scans. I'm referring to BCR, of course.
Another question for you. Don't be afraid. Tobias, I will jump to you later, right immediately after that.
Help me, Tobias.
The question is regarding the tracer itself. The questions are repeatedly asked, gallium-68 or fluorine-18, which one will be, at the end of the day, there?
Well, if you are purely talking about diagnostic accuracy, there's no demonstration of any superiority. I mean, there are comparisons in very small group of patients that have never led to any clinically relevant difference if we are talking about gallium and the good fluorinated one. There are, of course, logistical problems. I mean, if you don't have a radiopharmacy, you can only rely on fluorinated compound that you may purchase from a distributor. So if you don't have your own generator and radiopharmacy, you can only purchase a fluorinated one. At the same time, I'm not aware of any country where you can purchase that because there's no commercial license so far that's been given. And it's a matter of making some economical calculation because as we are doing, if you're using a kit for gallium labeling, you can scan up to something like 8 patients with 1 kit. And by an economy scale, it gets quite cheap to make it and quite easy. But I have to say, I'm lucky enough to working in a large department, so we can afford the generator, radiopharmacy, and radiopharmacist, and so on. So It's mostly about logistic and regulation nation by nation. There's not an absolute. It's very clear one point, 90% of the literature is around gallium PSMA 11. So if you want robust data, you can only go for gallium PSMA 11 nowadays.
Okay, Tobias. There are a lot of questions regarding PET's position at salvage. Can you clarify exactly what you do with the PET results? Let's say you had a patient who has a radical and a few months or years later, you see a rising PSA and you perform a PET and the PET is negative. First question to you, do you wait or do you consider that it might be a false negative result and you salvage, provided the patient belongs to the high-risk group at relapse?
Well, I think here we have the EAU guidelines and we have to follow them, because the early salvage radiation after radical prostatectomy is clearly superior, if indicated, than to wait until you see positive spots. And of course, if you have biochemical recurrence, you will have prostate cancer cells somewhere. And you can calculate the likelihood if it's a local recurrence or if it's more a systemic disease from, I don't know, when the relapse is taking place, how fast it's going. But I would first consider local salvage radiation. Don't wait for a PSMA PET scan to be positive.
That's an absolutely important point, and it's clearly highlighted in the 2021 guidelines, where clearly wrote if a salvage radiotherapy is needed, don't wait for a positive PET to salvage. Do it whatever the result is. The second question for you is, okay, you find something, you have a relapse and you do a PET PSMA and the PSMA is positive somewhere in the pelvis. What do you do? Nothing outside the pelvis, but somewhere in the pelvis. What are you doing? And later, and then I will tell you what the guidelines are saying in 2021.
Okay, I'm very interesting because I just got the notification that the new guidelines are out. So, but this is really a tricky one. And actually the guidelines until now, they really gave us nothing. They said, okay, upon systemic progression, I mean, let's say he had a radical prostatectomy, salvage radiation to the fossa, or maybe even to the lymph nodes, and now he's progressing. And first of all, the basis is, what is the life expectancy of this patient? What is his general condition? Of course, you need to consider that. And then to see, how likely do you think from a clinical perspective, does he have a really localized disease as the PSMA PET suggests? And if you think, yes, he has a good life expectancy, yes, it's likely that he has only a pelvic only recurrence, then, well, it's experimental therapy, but then you might consider doing a salvage radiation or doing a salvage lymph node dissection in such a patient. But you need to inform this patient that you don't have any data on superior oncological outcomes. You might tell him, well, we gain some time until he needs further systemic therapy. So maybe this is something that the patient wants to wish to keep hormonal treatment away a little bit. But there is right now too few data out to say you need to do a targeted therapy.
I fully agree. Let's say the guidelines suggest that if you go for salvage, then it should be combined with some form of hormonal therapy, which you never mentioned repeatedly. So I insist on that. It should be at least 6 months of agonist. And we have just the randomized trial that has been presented at ASTRO, not yet fully published, suggesting that whole pelvis plus prostate bed is better than prostate bed alone at an increased risk of toxicity, for sure. So, and we insist on the fact that targeted radiotherapy is still experimental. So clearly we don't know what to do with this. On the same side, if you find spots outside the pelvis, the question might be, do you avoid doing a salvage radiotherapy to the pelvis? We know there might be false negative and nobody knows. Now we're facing something even worse.
This is again a very tricky one, but I mean, like you said in the beginning about the primary staging, having now metastatic disease while being N0, N0, M0. I think in these studies or in this, we need a, well, let me say Rosetta Stone, something to translate. So we need actually conventional imaging. That would be the optimum side by side to the PSMA PET. And I think we still should not abandon, we have the data for the old imaging, let's say, we should not abandon that kind of treatment, but the importance now, or the advantage now is that you can inform the patient, well, on the special molecular imaging, we see something else. So that might be that, the PSA will not behave as we think it will, and then you need to discuss, of course, do you do targeted treatment or not? And well, we have indirect hints from the Oriole trial, for example, that we might treat better if we see everything and if we perform PSMA PET in these circumstances.
Well, Oriole suggested that when you don't treat PET positive spots, the outcome is poor. It doesn't show us that we need to treat these spots. So it's a predictive factor of results. It's a little bit different.
So that's so you're thinking about a radical prostatectomy person having a recurrence, and then you see on PSMA PET a metastatic lesion, but no local recurrence. So I mean, in these cases, we would inform the patient, of course, and then say, well, we should actually not really abandon local treatment, but include or consider also treating the metastatic lesion. I think it would probably be a mistake or to only treat locally when we know we have a distant metastatic lesion. So you could spare those patient toxicity. You don't have to treat with targeted therapy. You can say, well, you might end up getting systemic hormonal therapy if the PSA is progressing further on.
I agree, and I believe Stefano will agree also that you said repeatedly, you may, there's a risk, there's a risk. And I do believe that's a very important message. We need to be absolutely clear that at the end of the day, we don't know what we're doing. We know that we're seeing more precisely, not 100%, but much more precisely, but in fact, we don't know what to do. Stefano, a question for you. In your opinion, personal opinion, because you have such a lot of practice of that, what is the value in diagnostic or staging, not for treatment, for the CRPC patients with PET? Is it really useful, or is it just a waste of time and money?
Well, I always say never refer a patient to me just to have more information if you are not ready to change the treatment plan. If you are not in your mind, first of all, the management of the patient. I mean, never scan a patient just for a follow-up, never scan just to see how the situation is going and so on. So CRPC should be, first of all, in a clinical perspective put. It's such a large concept that, again, if it's because there's some problem on the therapy and you're suspecting that the patient is no longer responding or there is a discrepancy between PSA values and the clinical data and what's on, and you're suspecting that, for example, there is a spread somewhere, okay, it could make sense, again, if you have a therapeutic resource. But I wouldn't say that every CRPC patient is a good candidate for PSMA PET. It doesn't make any sense at all. There's no imaging in any clinical application that could make sense in any case. Well, maybe bone RX in fracture, but okay, if we are referring to advanced imaging, most likely it should always be in a clinical point of view. That's to say, would I use the information to change my patient management or not? Because if it's purely to get some more lesions, some more details, in my view, I'm sorry, I'm a bit conservative on that, even monitoring the response to therapy is very much questionable to be done with PSMA, very much. Apart from the lack of data, there's also not such a big rationale, because the other application you mentioned it before, we have no good, robust ABM data, but at least we have a strong rationale behind in some cases. In this, I doubt that there is such a strong rationale.
Tobias, regarding non-metastatic CRPC, do you really believe there's a place for any form of PET for staging? I insist, staging.
I personally don't recommend PSMA PET in this setting, because I think the change of management would be minimal. We have, it is a patient for medical treatment, and we have drugs that will work. They don't care about if you see a metastatic lesion or not, they will work. So I think if you have conventional imaging, and if you don't, you can exclude major findings, I don't know, so something that needs to be irradiated before you have a bone fracture or something. But I don't think there's a big role for PET PSMA there.
And very final question, because I think we're a little bit ahead of schedule. Stefano, can you clarify why in the randomized trial that you presented on theragnostic versus cabazitaxel, we had to do a PET PSMA and an FDG PSMA?
That is the Australian approach, which indeed is not used in the vision. That's to say, if you want to enrich the likelihood of good response to treatment, then you try to do your best to avoid treating the non-responder. And if you have a very high FDG uptake, higher than PSMA, then you can, again, on a rational, pretend that it is a very aggressive disease, unlikely to respond. So you just want to get rid of the very rapidly progressive, worst prognostic situation. That's the very simple rationale, which is not, again, we have no data on that. Vision trial has not been published so far. We'll see if they are comparable or not. It could be a strategy. It's copied to some extent by what we do in neuroendocrine tumor, where we have, again, a receptor, which is the somatostatin receptor, which is put together with the FDG uptake in order to select the patients. Honestly, I have no clue to tell you which is the best strategy right now.
Okay, I do believe we're a little bit late. Very last question, and that's a question again for you, Stefano. I just read the question. Should we take it as contraindication to radioligand therapy in case a PSMA avid focus is noted not related to prostate metastasis, for example, in lung?
Oh, well. It's a cool question because it's not so frequent, but I have to tell you, if you have a hotspot which cannot be related to prostatic cancer, as I told you, a primary lung cancer will be PSMA avid, but also a metastasis within the lung. So if you see such a hotspot, you have to do a biopsy on that. And if it's a MET, you can clearly treat it. If it's a secondary primary, well, it's not a contraindication, but you have to probably first take care of the survival profile that the patient is now having due to the secondary malignancy in the lung. So it's articulated. Okay,
last comment. Let me remind you that all this webinar will be available on YouTube, on the ESU YouTube, within 24 hours from now. So if you have unclear points, you might see it again and again and again and become an expert on that. So I thank you all, especially the two speakers and those who asked questions for that. And it was really a pleasure. And I heard I hope you learned a lot of things. Personally, I did. So bye-bye, everyone.
Okay, bye-bye.
Bye-bye.